Welcome, everyone, to the February 13th meeting of the Washington Hospital Board of Directors. I invite you all to stand and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. Dee, if you'd take the roll.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Epen.
Present.
Director Wallace.
Present.
Director Danielson.
Thank you, Dee. We're ready now for an education session. And Nancy, if you could introduce that for us.
I think we're starting this evening with Carmen Williams, RN. But our subject is Prime and the Quest for Zero. And this is a program about our obstetrics program here at Washington Hospital. Carmen, are you the first to speak or the second?
You're doing it as a team.
It's
a team. It's a team.
a team. Okay, well then I'm going to read your introductions. Please come on up. Carmen Williams is a registered nurse with a master's degree in nursing. She began her career at Washington Hospital in 1993 as a bedside nurse in the birthing center. She holds specialty certifications as a certified inpatient obstetric nurse. She's grown professionally in her 25 years here and is currently the senior director of our birthing center, pediatrics, the special care nursery, maternal child health education, and the prenatal diagnostic center. Also speaking tonight is Sabrina Valade. She's a strategic projects senior analyst and works on the Prime program, which you're going to learn a little bit more about tonight. She joined Washington Hospital Healthcare System in 2017 as a strategic projects senior analyst with the Prime program. Prime stands for Public Hospital Redesign and Incentives Program. In her role, she collaborates with operational teams to achieve improvements in care and expand service delivery in alignment with the Prime program. Prior to 2017, she served as a health center manager for Stanford Healthcare, where she oversaw operations of innovative employer-based primary care clinic. Prior to her role at Stanford, she served for more than 17 years at Santa Clara Valley Medical Center in San Jose, California, where she held several roles during her tenure, all focused on supporting the expansion and improvement of care to patients. While at Santa Clara Valley Medical Center, she worked on teams to implement population health management for 7 regional primary care clinics and several specialty clinics, supported delivery system transformation through the Delivery System Reform Incentive Pool, and oversaw multiple data systems. She began her career in healthcare at the Children's Health Initiative, which was a first in-nation effort at universal health care access for children. She received her master's degree in public health from San Jose State in 2002 and her BS in health sciences in 2000, also from San Jose State University. She's also taught undergrad classes at San Jose State University in health sciences and helped to develop 2 new courses there. So I'm going to turn the program over to Sabrina and Carmen.
Okay, terrific. Thank you very much. It is our pleasure tonight to jointly present an overview of the Washington Hospital Maternal Child Health. The purpose of today's presentation, first and foremost, is to share with you, our board, and with the community, the services that are offered through maternal child health. We will share with you some of our innovations and best practices, and we have props, and we will do demonstrations. And also, like Nancy said, we will share with you some of the tools that we use to drive achievement and performance, including the Prime program. So with that, I will turn it over to Carmen, who will introduce the services that are available in our maternal child health service.
So when we say maternal child health, sometimes, especially our community, may not really realize what all that encompass. So for us, first thing, the patients are in the center of our care throughout the whole maternal child department. We have maternal child education, which is located out at Beacon. It's where all our classes are held. We also have a prenatal diagnostic center, which is located at 1900. We have the birthing center, which is in our main campus on the second floor. We also have special care nursery, which is also on the second floor of the main campus. And pediatrics. Those are all the areas that's covered through maternal child health. We have a clinical operations, which is a multidisciplinary group created in 2010, and it has a large amount of different entities as far as physicians and the staff throughout the hospital. We have our neonatologists, the nurse managers, assistant nurse managers, social workers, and we meet together once a month to discuss evidence-based practices and make clinical decisions that deliver the best of care for our patients. At the Maternal Child Care Education Center, we offer more than 10 classes. Classes are available to all community members, and we also have classes that are also people that are not in our community or may not even deliver at our hospital, but we do have a large amount of classes that are offered, and so we draw people from everywhere. Some of our ones that are really popular is infant massage that helps with those babies that are really fussy. Mastering multiples are for those who might have twins. Occasionally we have triplets, not very often. Prenatal yoga and Bollywood are a couple of the other ones that are super popular, and one of our most popular ones are Baby and Me. Baby and Me has been going on for many, many, many years, and it's when the mom and baby come for a free class several times during the week, and they just bond together. There's an instructor that works with them so that they have time with their babies and with other mothers, and we receive Christmas cards from this group where at 8 years of age, they're getting together for Christmas parties. So they really do bond, and this is a worthwhile service for our community, for our new moms. The Prenatal Diagnostic Center, I know that you've already had a presentation for them. Opened in July 24th, 2017. We've completed already over 2,600 visits since opening. And it's where they get advanced prenatal care, which is now available to our community using the state-of-the-art technology. We have high-level ultrasounds and genetic testing that's done there, and our community members who used to have to travel elsewhere for this testing can get it for us. It's led by a maternal fetal medicine specialist, Dr. Chu, who see our patients, and we are one of the few prenatal diagnostic centers that offer fetal echocardiograms. Our special care nursery, which is led also in collaboration with UCSF, Dr. McGuire is our chief. It's an 11-bed intermediate unit, and we just this past week and a half had 10 in there, so we were almost at our max. Anyway, the babies receive exceptional care through the in our community now through UCSF neonatologists and pediatricians. We have family rooms that are available for those moms once they are discharged, so that they're able to be close to their babies, to breastfeed and be there with their babies through the entire stay of their baby's stay here at the special care nursery, so that they don't have to travel at all. So our families are now able to stay close to their babies and not have to travel elsewhere for these babies. Our SCN staff attend our high-risk deliveries. We have babies that used to be transferred that are no longer transferred now because we have what we call bubble CPAP, and we're able to maintain them as far as their respiratory status is concerned here and keep them here at home. One really important part about this is that we have our volunteer cuddlers. And for those of you who don't know who cuddlers are, they're led by Jenny Yee, our own Jenny Yee, and they actually come in and just hold our babies. This has been proven through research how important this is for the babies to grow. So when mom and dad aren't able to be there, our cuddlers are. I'd also like to take the opportunity to thank our volunteers for being there for us, for extending this program, and I'll talk about that a little bit later tonight, but also because it was them who also have supported the facing of a facelift like of our nursery by donating a very generous sum of money to make that happen for us. So thank you for that. We also have a pediatric department, and though it may be small, it's really important because we are able to serve our newborns and our up from newborns to 13 years of age right here in our community at lower acuities. Our patients usually come from either a transfer from the birthing center or directly from pediatricians' offices or the emergency room. These pediatricians on this unit are also UCSF pediatricians, and so the hospitalists are here 24/7. We are able to take care of babies with many common reasons for admissions, like respiratory, babies that are jaundice, gastrointestinal problem, post-surgical patients, and babies that are born with substance exposure. We are one of the first hospitals in the Bay Area to develop the Eat, Sleep, and Console program, which is called ESC. And what this does is babies that have substance exposure, these babies used to be put on a scale, and if they had a certain number, they would have to be transferred to the special care nursery. And then after they were transferred to special care nursery, they would have to be given medication like morphine or something to help them to get through the withdrawals that they would have to go through. So Eat, Sleep, and Console is just what it says, Eat, Sleep, and Console. We're checking to see if they're eating okay, if they're sleeping okay, and can we console them? Because these babies need lots of cuddling, our wonderful cuddlers stepped up to the plate for us again when we just had a patient who had this, and they came in and they were available day or night anytime that we couldn't get a baby to console. As a result, because these babies have to be in the hospital for a minimum of 5 days, they left the birthing center, went to pediatrics, and our cuddlers followed them all the way through. And this baby ended up being an extended stay, and it was probably about 10 days that they were there. And I want you to know, 10 days our cuddlers were available. So it was just thank you again for that, because this, as a result, this baby never had to get any morphine, never had to be transferred to the special care nursery away from mom, and was able to stay in the room, and we were able to accomplish what we really wanted to do for these babies. Okay. Our birthing center is award-winning family center birthing center. We do have state-of-the-art technology and support for our moms and families. We have about 140 deliveries a month. All of our rooms are LDRPs, which means that patients labor, deliver, recover, and stay there. And we try to discharge them from that room. If we're not able to, we do have an overflow area that we take them to on 2 South, so that, again, a private room, a bed for dad, and they're able to be there with their families. We have the obstetricians and anesthesiologists that are 24/7 that are employed by our hospital, and they're there 24/7 to support these moms. We receive baby-friendly designation for excellence in breastfeeding and mother-baby bonding.
So in addition to all the many services that Carmen just described, the Birthing Center is constantly working on new innovations and initiatives to provide the best care to our community. So some of those initiatives that are underway include Lean, Prime, the Quest for Zero, extensive work to increase our rates of exclusive breastfeeding, work to decrease our C-section rates, patient safety drills, hemorrhage risk reduction, and also trial of labor after C-section. And so for the remaining presentation, we will go through each one of those initiatives and talk about the improvements that are underway.
So Lean, we are blessed at this facility to have this approach to patient care, and it is throughout the whole hospital. So OB was not exempted. They were a part of it too. And we have gone through many initiatives, many Kaizen workshops, made a lot of changes because of it. But just to touch on a few of them, we developed a special green pass that is a OB, for OB patients and families. And what that is that if you've ever been in the lobby and you see a line of people waiting to be signed in to whoever they're going to visit, we identified that we wanted our mothers who needed to go up for either testing or because they were in labor to be able to come up quicker. So what was developed in this particular workshop was what we call a birthing center pass. So it's a green pass that our patients are given, and so all they have to do is to enter the hospital, raise up their pass, and the person who's there at the front signing them in will allow them to go in with their significant other. If there are a group of people with them, because sometimes there's a whole family coming through for labor, They will have to wait and sign in like everybody else do, but the significant other and that person are able to just go straight through. So that way they don't have to worry about it. Now, when they get to our floor, there's another layer of security there. So we make sure that it is safe to be able to do this, use this pass and get people up to the second floor. We also worked on getting our patients out by 11 a.m., which is what our discharge time is. And in the past, it was kind of difficult to get everybody out, but through our workshop, we identified things that were stopping us from getting them out on time. And you might wonder, why is it important that a patient is out by 11 o'clock? Well, when you have LDRPs, if they're full, you have a person come in labor, we have to go to the recovery room to labor somebody if we can't get beds that are open. So we try to make sure that we get everybody out in time. So we developed several things that we did in order to help make that happen, like making sure all the photos for baby are taken the day before, the birth certificates are done the day before. Anyway, we were able to get 39% more moms and babies to be out on time by doing this. We also have a twice daily nursing huddle, which helps with communication, and that's the board you see. And every day from at 7 a.m. and 7 p.m., the staff comes around this board. We talk about all our different metrics and things that we need to be doing. We have a place for ideas that the nurses participate in. And then we have, if you see at the very bottom, there's little stars there. Those stars are for nurses, and they're able to either give themselves a star because they were so wonderful that day, or one of their coworkers may give them a star. Either way, I always tell them, well, if nobody gives you a star and you came in extra to help us, love yourself. Give yourself the star. So they give themselves stars, and at the end of the month, we do a drawing, and they get a gift for that. Just an incentive for the staff to just continue to doing the excellent job that they're doing.
So another quality improvement initiative we have underway is called PRIME, and that is the opportunity that affords me to work so close with the OB team. So PRIME stands for Public Hospitals, Incentives, and Medi-Cal, and it is a 5-year Medi-Cal waiver program that provides state and federal funding to public hospitals to both launch new services and also test and spread promising new models of care. So the way that PRIME works is that we only receive funding from the state and federal government if our targets are reached. And so we report to the state regularly on our Medi-Cal patients, and that's where we have to achieve certain performance targets. Because we don't treat patients any differently based on their payer class, every improvement that we make applies to all of our patients. Only the reporting that we do for the state is just for Medi-Cal. And so we have 2 PRIME projects. One of them we'll talk about tonight, and another one we won't. The project that I'll talk about is improvements in perinatal care. That is the project that I work with Carmen and her team. We also have another project, which is advanced illness planning and care, and we won't talk about that one tonight. So as part of PRIME, one of our goals was to design and launch the Prenatal Diagnostic Center, which we successfully did, and Carmen just talked about. Another goal of ours is to maintain our baby-friendly redesignation. And then we have several quality improvement metrics in which we're consistently striving to improve that rate, and we draw down funds if we achieve that. We're so fortunate that so far in the 3 years we've been involved with PRIME, we've met 96% of our performance improvement targets. That's 25 out of 26 goals. We've exceeded the state's threshold for top performance for multiple metrics. And because of our success, we were invited as a district hospital to present at the 2018 state legislative briefing. And so we did that, talking about the great work that we're doing. I wanted to share with you just one example of a tool that we use in PRIME to drive performance improvement. I won't go through all of the data, even though data is my personal love, but this is a dashboard that we produce, and every month I meet with Carmen and her team to look at where we are relative to each metric. Are we making progress? Are we behind? Are the interventions we've implemented making a difference? This is our December dashboard, and you can see it's predominantly green, and we're happy about that. So the area that is red gives us an indication that we're not on target for that, and lets us know that we need to look at our efforts in that area. So actually in the later part of the presentation, we'll be talking quite a bit about the work we have underway to improve our C-section rate, which is the metric we're not at goal yet currently.
We also participate in Quest for Zero, Excellence in OB, and the Quest for Zero program is a program that is done through our insurance carriers, Beta, and it is all in order to increase the quality of care, and it's to have zero preventable errors. We want to decrease all the avoidable risk for moms and babies and improve reliability and communication while we're doing that. We are one of the top performing Beta hospitals statewide. We have 100% compliance with the doctors and the staff. We have 2 tiers that we meet in order to do this. Tier 1 involves every person that takes care of laboring moms to pass a fetal monitoring course. And our physicians are 100% when it comes to getting this done, which is really good for us because that's one of the problems that many hospitals have is getting all the physicians on board with it. And our physicians are great as far as that's concerned. We have had 4 years of successful coverage of Tier 1 and Tier 2. Tier 2 is a tier that you then have to do some other type of quality measure. So you can see some of them that we've done is shoulder dystocia. That means the shoulder is stuck at delivery. And how do we make sure that we take care of this in a quick way so that baby's okay and mom's okay? Vacuum bottle, and also medication safety and hemorrhage. And that's that's our trophy that you see up there for 2018. Exclusive breastfeeding is also one of the measures that we work on, and the American Academy of Pediatrics recommends that babies exclusively breastfeed for the first 6 months of life. And so we work really hard at trying to give moms the tools that they need in order to make that happen. There are many benefits of breastfeeding, as you see listed there. We nationally are recognized for best practices on an everyday basis. We initiate breastfeeding within the first 30 minutes of life. Even in the operating rooms, our babies are placed skin to skin with their moms as long as they're medically able to do that, and they usually breastfeed within the first hour of time. Most of the time it's 30 minutes. We have lactation consultants that are here and work with us 100% during the day. On evenings we have someone 4 days a week, and on nights we have someone 3 days a week, which is very unusual to be able to have a coverage for that period of time. Of course, we practice rooming in. Our babies stay with their parents throughout the whole hospitalization unless there's a reason that they have to go to special care nursery. And we encourage breastfeeding on demand, and we do follow-up calls. Our baby-friendly designation for 2014, and we're to be redesignated this year, 2019. It's a survey that's quite rigorous, that's on site. We have had the support of our administration, Stephanie, Nancy, thank you so much, because without them we couldn't even start having this designation. They wouldn't even begin it without their approval, and we've been supported a lot through them. There's only 27% of all U.S. births happen in a baby-friendly hospital. 10 steps of successful breastfeeding. You will see this throughout the whole hospital. It's required through Baby Friendly that any place that a mom may walk through the door, there has to be a place posted for the 10 steps of successful breastfeeding.
So as Carmen's describing, increasing rates of exclusive breastfeeding is extremely important to us. And so there are several initiatives we'll talk about relative to that. One of them is PRIME. It is one of our PRIME goals to reach the state's threshold for highest performance by June. So that's just a couple more months. We're really close.
Yes.
We are already a top performing hospital statewide for PRIME. And one of our activities through PRIME is that we participate in a learning collaborative with other high performing hospitals in the state. So we share with them our best practices, and we learn their best practices, and that really accelerates the improvement process.
So babies in the past, if their blood sugar dropped, we automatically gave them formula. Now we no longer do that. Starting 2018, we started giving them glucose gel, which helps bring their blood sugars up, and then we put them to breast, which helps even more. It has increased our exclusive breastfeeding rate for low blood sugar babies has gone up by 42%. Our newest endeavor, thanks again to administrations and Stephanie, Nancy, we are so grateful that you guys supported us in submitting our tissue bank license to offer donor breast milk. So our patients who desire will be offered breast milk instead of formula if their babies need supplemented at all. Now, when we talk about how much we really push breastfeeding, we think it's really important. We do think it's the best way for our babies to feed, but we also realize there are some moms that like to bottle feed. And I want to make sure that everyone understand that we support those moms just as much as we do the ones that are breastfeeding. So we teach them how important it is to hold their baby close, to have good contact, even though they're bottle feeding their baby, to do skin to skin. And we teach them how to prepare their formula. So we support the moms that decide that they do not want to breastfeed as much as we do those who want to breastfeed. Another initiative we have is improving obstetrical hemorrhage and the outcomes of hemorrhages. It's the leading cause of maternal morbidity and mortality. So usually if we lose a mom today in OB, it's because they pretty much bled too much. And so we've been working on this. We've initiated safety bundles that have seen 20.8% reduction in maternal morbidity over a 2-year period. So we've implemented through Prime 16 safety bundles, and we also work with CMQCC. There's a collaborative for reduction of hemorrhages, and we have a massive blood transfusion protocol. We have a hemorrhage card. We have standard work when it comes to preventing moms from bleeding out. We have a special balloon that we put into the uterus that's like a tamponade that presses against the vessels and stop them from bleeding so much. Our newest thing is that we use tranexamic acid. And tranexamic acid is a medication that we give IV that's often given to trauma patients that helps stop bleeding, and we've been really successful through that. We're also working on a process where we're working with patients that refuse blood products, and this is one of the medications we can use for that. So patient safety drills. Of course, because we don't have that many emergencies on our floor, the only way that we can make sure that we're ready when we do have one is by having drills. So we've established several different drills for postpartum hemorrhage. We have a mock code pink committee that works together with the SEN, pediatrics, and OB in order to work together and have drills on both shifts, day and night, so that we can identify places that we need to improve and be prepared for when we do have one of these emergencies. Also, we have a code green team, and we do infant security drills.
So if you recall, when I showed that dashboard, we had a lot of green and we had one area that was red. And that area that was red is our C-section rate. And so the remaining slides are going to be talking about the work that we're doing relative to C-sections. So first question is, why support vaginal birth? So C-section rates have increased by about 60% since 1996, with no demonstrable improvement in outcomes for moms or babies. Moms who have C-sections have higher maternal complication rates. They need longer recoveries. Infants that are born via C-section have higher special care nursery admission rates. And because a C-section is a major abdominal surgery, there are significant risks associated with any surgery. So our goals here at Washington are first to increase vaginal deliveries for first-time moms. If we can prevent a woman from having her first C-section, then we can often prevent subsequent C-sections. So that's really a focus for us. But overall, we're looking at an overall reduction in our C-section rate for all moms. So OB is engaged in several initiatives to that end. The first one is we're involved in a pretty extensive collaborative with CMQCC to promote vaginal birth, and the next slide I will talk about what that means. The OB team has done a great deal of education for our nursing staff and for physicians. The birthing center offers TOLAC, which is a trial of labor after C-section, which means if a mom did have a C-section the first time, with her doctor's approval, she can attempt a vaginal birth for second and subsequent babies. We also use mobile fetal telemetry, and we are using innovative tools such as the peanut ball and exercise balls, which we will demonstrate for you shortly. Participation in CMQCC. CMQCC stands for California Maternal Quality Care Collaborative. This is an organization in California that's dedicated to ending preventable morbidity and mortality for moms. The way they do that is by implementing evidence-based toolkits, engaging in statewide collaboratives, and they also manage a statewide data center. Since CMQCC began in 2006, maternal morbidity in California has fallen by 55%, while rates in the rest of the nation continue to climb. So these are very significant interventions and very evidence-based interventions. So our participation with them relative to C-sections is we're participating in an 18-month collaborative to support vaginal birth and reduce C-section. It's an 18-month commitment that our OB team made. We are working through the implementation of evidence-based bundles. We do monthly calls with our OB team and with CMQCC, and we have regular site visits where they come on site and work with us to implement this evidence-based bundle. As part of the work to reduce C-sections, the teams have also done a lot of physician and education nursing. So we had a speaker from the American College of Obstetrics and Gynecologists speak to our teams. Oh, we have a pregnant mom joining us here today. She might be in labor soon. We also have had our CMQCC mentors come and speak to our teams. And actually, just 2 weeks ago, we had UCSF on site, in fact, in this very room, and we delivered a 6-hour training to our RNs about how to support patients through vaginal birth. So Yvonne and Carmen are going to demonstrate for us some of the innovative tools that we're using in our birthing center. So the first one is mobile telemetry, and so I'm going to let the skit speak for itself, but the idea is to demonstrate for you some of the tools that we use. These are all evidence-based tools that are proven to decrease the C-section rate.
And I'd like to take the opportunity right now to thank the board for our mobile telemetry, which you all approved, and we're going to show you in just a minute what a difference it will make for our patients.
So Ms. Williams, while you're here in labor, we're going to go ahead and monitor your baby. You're going to be receiving some medication tonight that will require you to have some continuous monitoring while you're here. So. What can I do to help you at this time?
Oh, I'm not sure.
Let's try the chair.
You know what would really help? If I wasn't confined to this bed and if I didn't have to be in this little section the entire time. I mean, I can't move. They say that I'm on medication, that I have to be monitored all the time. So there's nothing I can do besides just sit here. And it's really, really hard.
I know. Take a deep breath. That's okay. What we have is a device called fetal telemetry, which will let you get up and walk. So let me transition you over to that.
Oh, thank you so much. That's going to make a huge difference, just to be able to move around.
And we can monitor your baby at the nurse's station, and we can watch you as you walk around the unit. So you have the ability.
Thank you so much. This is so much
Let's walk
better.
together, okay?
Oh, here comes another one.
All right.
Oh,
Let's kind of dance this baby out.
goodness.
There we go.
Oh,
You got it.
oh, my back is just killing me. The pressure from my back is just so bad.
You know what we have that is evidence-based to improve your comfort is a birthing ball.
Oh, thank you so much. Oh,
So if you sit
anything
here,
at this time will help.
There we go.
Oh,
rock side to side.
this feels so much better. Thank you so much. Being able to walk around and having this ball. Oh, I could just feel my baby just moving down already.
You know what? Looking at the monitor, Mrs. Williams, I believe that your baby might be getting closer.
Oh, I'm
Let's
starting to
get
feel a little pressure.
All right, let's get you back in bed and have a look-see. All right.
Okay. Oh, this is like a miracle. Thank you guys so much.
Oh, you're welcome.
Thanks to
You're
the
welcome.
board too.
There we go.
Oh,
All right.
Thank you.
All right, so I'll go ahead and check you.
Okay.
My goodness, I do believe that your baby's coming quite nicely. We're almost there. We're about 9 centimeters.
Bless Pete, I'm so glad it's almost over.
We have a delightful new toy. This is called a peanut ball, and it is an evidence-based practice of an exercise ball.
Oh, thank you
that
so
we can
much.
use to help you open up your pelvis to bring the baby down. You can hold
That
on to
feels
while
so
you're
much
in labor.
better.
You can even push while you're getting ready
Yes.
to. So if you're getting ready to push, then you can go ahead and hold on to this while you're doing that.
Oh, this feels so much better.
Oh, I'm so
Oh,
glad.
thank you.
You're welcome. You're welcome.
Oh,
All right.
oh,
There we go.
thank you. Thank you.
Well done.
So there's So those are some of the tools that are being used by our OB team. In addition to providing patient comfort and some options, they are evidence-based, shown to decrease length of labor and to decrease the C-section rate. So those are some tools that we're using here. Now, because our Director of Maternal Child Health just had a baby, she might be a little tired. So I'll go over the slide that talks about next steps for maternal child health. So the first 5 items on there are initiatives we've talked about during the presentation: baby-friendly redesignation, CMQCC collaborative, prime work. All of that work continues. In addition to that, the last 5 bullets we haven't talked about yet. The first is the extension of our cuddler program. The team is developing an initiative for improving outcomes in hypertensive and preeclamptic patients, working on developing an antenatal unit for high-risk moms. Those are moms that are not ready to deliver yet, but need to be inpatient for one reason or another. The team is working on certification for our Prenatal Diagnostic Center, and also a facelift will be underway for our special care nursery. So that concludes our presentation and birth, and we would be happy to answer any questions that you have.
Thank you.
Much. That was extremely entertaining. but also very, very educational. What a wonderful,
Thank you.
wonderful way of presenting all the things you offer in maternal health care. I was unaware of some of those. That was really wonderful.
Thank you.
Any other board members have comments? Or?
I think it was great to see the telemetry unit put into action. So thank you for visualizing that for us.
You're welcome.
Thank you.
All right. Thanks
That
again.
was a lot of fun. We have it on tape. So.
Forever recorded.
Thank you. Thank you again. Very, very well done. That'll be the highlight of the board meeting tonight.
I think so.
We'll now consider the minutes of January 9, 21, and 28 of 2019.
Mr. President, I move for approval of the minutes for January 9, 21, and 28, 2019.
We have a motion and a second. Dee, if you would take the roll.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Eben,
Aye.
Director Wallace,
Aye.
Director Danielson.
That motion passes. Thank you, Dee. Do we have any oral communications this evening?
No, we do not.
I don't see any. Thank you. We'll now take up our written communications. Dr. Choi.
Good evening. I'm happy to present the proposed credentialing items for tonight. Under appointments, we have 4. The first is Martha Elster, MD, for pediatrics, Christopher Cole, DO, for anesthesia, Julia Lee, radiology, and Dr. Harpreet Singh for family medicine. Under temporary privileges, we have Christopher Cole, DO, for anesthesia. Under reappointments for 2-year, we have the following: Elizabeth Arias, MD, internal medicine, Dr. Bhupinder Bhandari, medicine GI, PA Anna Chun, Dr. Gordon Epstein, otolaryngology, Dr. Narayana Gunda, internal medicine, Dr. Ash Jain, interventional cardiology, Dr. Puya Jazayiri, anesthesia, Dr. Glara Kang, pediatrics, Dr. Chai Kyong Lau, internal medicine, Dr. David Lee, hematology oncology, Dr. Patricia Lee, intensivist, Dr. Philip Lee, internal medicine hospitalist, Dr. Duan Liu, intensivist, Dr. William Nicholson, cardiology, Dr. Bruce Nixon, radiology, Dr. Carlos Perez, internal medicine hospitalist, and Dr. Steve Pham, emergency medicine, and Dr. Lucia Yamena, nephrology. 1-year reappointments include Dr. Ranjit Reen, internal medicine. Transfer in staff category, we have 1 physician, Dr. Chai Kyong Lau, for internal medicine, moving from active to ambulatory. Under the category of extension of proctorship and provisional category, we have Dr. Curtis Wozniak of cardiothoracic surgery. There are 2 application withdrawals, including D.O. Fadi Aradaki and Dr. Adur Adroni. Resignations include Dr. Stephen Franzino, of Orthopedics, and Dr. Mark Liang, Internal Medicine Hospitalist. That completes my report.
Thank you very much. We have an interesting situation tonight with the medical staff approvals. We have Dr. Nicholson, who is on the board of directors, sitting next to me, and we have his wife, Dr. Lucia Jimenez, that are there. Dr. Nicholson will not participate in the vote on himself and his wife, as is required by conflicts of interest and other things. So, first of all, I'll maintain a motion from Dr. Nicholson on the other medical staff people.
Thank you, Mr. President. I move that the board approve the credentialing action items presented by Dr. Choi, with the exception of those credentialing action items related to myself, William Nicholson, and my wife, Lucia Jimenez.
Do we have a second? We have a second. Dee, if you would take the roll, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Eapen,
Aye.
Director Wallace,
Aye.
Director Danielson.
Good. That motion passes. Now we'll have Mike Wallace give us a motion for the remaining 2 physicians.
Mr. President, I move that the board approve the credentialing action items pertaining to William Nicholson, MD, and Lucia Jimenez, MD, as presented by Dr. Choi.
Thank you, Mr. Wallace. Do we have a second? We have a motion and a second. Now, Dee, if you would take the roll on those items.
Director Stewart,
Aye.
Director Nicholson,
I abstain.
Director Eapen,
Aye.
Director Wallace,
Aye.
Director Danielson.
Great. That motion also passes. It's good to have you back on the medical staff.
Thank you very much. Appreciate that. My wife, I'm sure, appreciates that as well.
Yes. Thank you. We'll now have our Service League report. Jeannie, if you would do that, please.
Oh, it's my honor to be here for the last time in my term. Thank you all for your warmth and your welcome and just the experience. So I bring you greetings from the volunteers. It's been a great year as I look back, and we've made some wonderful changes. You have them in your report, but the one thing that I wanted to highlight was this last year, as volunteers give their time, we keep track of those hours, and this past year, the highest earning volunteer was noted at 10,500 hours. That's her lifetime of serving at Washington Hospital. The thing about her is she's 99 years old. In 2 months, she will be 100, and she is still an active volunteer. So anyway, her name is Emily Hunt, and she has been making things for our community, for our hospital, for our babies, bonnets and heart pillows for our women's clinic, and tireless. She'll work at home. She comes in once a month and works with the ladies, but 99 years old, 10,500 hours. So I just wanted to give a shout out to Emily. May her tribe increase.
Thank you. Thank you, Jeannie. Hopefully we can all remain active to those numbers. That's wonderful.
Yeah.
Dr. Choi will now entertain the medical staff report.
I'm happy to say that we have 593 members of medical staff, of which 357 are active.
Thank you. Now we'll have the hospital calendar report. Nancy?
We'll start with the video, please.
Past health promotions and outreach events. During the month of January, Lucy Hernandez, Community Outreach Manager, provided 8 hand hygiene presentations for students at Wybell Elementary School in Fremont and Kennedy Elementary School in Newark. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 202 students participated. On Saturday, January 12th, Washington Hospital staff provided blood pressure screenings along with health and nutrition information at the Health and Wellness Fair, co-hosted by Schilling Elementary School and Mexico Tortilla Factory in Delhi in Newark. More than 100 people attended the event and 37 blood pressure screenings were provided. On Thursday, January 17th, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented Fit is the New Skinny. 18 people attended. On Tuesday, January 22nd and Thursday, January 24th, Washington Sports Medicine hosted sports physical clinics for local high school students. Each student received an assessment and physical to ensure they meet the California Interscholastic Federation requirements in order to play sports. Medical Director Dr. Russell Nord, along with other providers from the Washington Township Medical Foundation, provided the examinations. Athletes also received orthopedic screenings by certified athletic trainers. Each athlete paid $20, which will be donated to the schools for sports medicine supplies. 126 students received sports physicals. On Sunday, February 10th, as part of the Speakers Bureau program, Dr. Seema Sehgal, psychiatrist, participated in a panel discussion with other experts on teen mental health during the In the Face of the Perfect Storm event at Mission San Jose High School in Fremont. 120 people attended. On Monday, February 11th, Dr. Ramin Beghi, cardiothoracic surgeon, presented aortic valve disease treatment options including TAVR. 29 people attended. Upcoming health promotions and community outreach events. On Wednesday, February 20th, from 6 to 8 p.m., Dr. Anna Malai Virapan, gastroenterology, and Kimberly Alvari, Director of Food and Clinical Nutrition Services and Chief of Patient Experience, will present Colorectal Cancer, Foods to Eat and Avoid. On Thursday, February 21st, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present Healthy Gut, Healthy You. On Saturday, February 23rd, from 10 a.m. to 1 p.m., Washington Township Medical Foundation will host a special health fair at their Newark location. This fun and free community event includes glucose, cholesterol, blood pressure, and body mass index screenings, and an opportunity to talk to experts on diabetes, nutrition, heart disease, and stroke. Registration is encouraged for health screening priority. To register, call 800-963-7070. On Wednesday, March 6th, from 6 to 8 p.m., experts from Fremont Bank will present How to Prevent Financial Elder Abuse and Fraud. At this seminar, learn about the most common financial frauds and scams targeting seniors. Washington Hospital and Fremont Bank are co-hosting this important educational seminar. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. January's featured topic was Women's Health, featuring Dr. William Degoni, General Surgeon and Medical Director of the Women's Center, plus articles on women's heart health and preventative medicine and routine screenings. The Washington Hospital Healthcare Foundation Report. On Tuesday, January 29th, the Foundation held its annual general meeting for trustees and members. At the meeting, trustees elected Dr. Karanthi Achanta, Sophia Ahmad, Nicole Dutra, and Eileen Reiner as new trustees. At the annual meeting, the president of the foundation, Helen Kennedy, presented Nancy Farber, Chief Executive Officer of Washington Hospital, with a check in the amount of $1.5 million from proceeds raised through the capital campaign to support equipment needs of the Morris Hyman Critical Care Pavilion. The foundation celebrated the amount of pledges and donations supporting the pavilion, which have totaled $9.5 million to date. The foundation also made a gift of $10,000 to Pathways Home Health and Hospice. The foundation will host the 34th annual golf tournament at Castlewood Country Club on Thursday, May 2, 2019. Held in memory of Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. To reserve your foursome or to sponsor the event, please call Washington Hospital Healthcare Foundation at 510-818-7350. Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District board members attended the Elegant Affair hosted by the League of Volunteers on Friday, February 8th. Washington on Wheels, WOW, Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of January, WOW served community members at the following locations: in Fremont, the Family Resource Center and TCV Food Bank and Thrift Store; in Union City, the Ruggieri Senior Center, Union City Family Center, and Our Lady of the Rosary Church; in Newark, the Viola Blythe Community Services Center and the Salvation Army. These community partners provide social services to families in need and the homeless population. WOW also provided health services at Revance Therapeutics Incorporated, a biotechnology company in Newark. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of January was 62. Internet and social media marketing. Washington Hospital's website serves as a central source of information for the communities the district serves and beyond. The hospital's employment section was January's most viewed webpage with 48,981 views. The hospital's social media presence is measured through total reach and engagement stats. The total reach statistic represents the number of people who saw a Washington Hospital Facebook post. Social media posts may reach a user via a newsfeed, which is most common, a user's page timeline, or via a direct link to a hospital post. The engagement statistic represents users who liked, commented, shared, or clicked on a Washington Hospital Facebook post. InHealth, Channel 78. During the month of January, Washington Hospital's cable channel 78, InHealth, aired a health and wellness program titled The Link Between Hepatitis B and Liver Cancer, a Diabetes Matters program called Latino Food Made Healthy, two specials from the 2018 Diabetes Health Fair titled Diabetes Care and Eat for Diabetes. InHealth also aired the January Board of Directors meeting. Additional events and announcements. On Friday, January 25th, Washington Hospital held a Rose Garden Remembrance. The event provided an opportunity for the hospital community to remember those who have passed away while serving as Washington Hospital employees, physicians, volunteers, or board members. Jamie Tippett and Dr. Jeffrey Kishiyama were remembered at the event. J.B. Goodyear, Spiritual Care Coordinator, provided reflections. For more information on any of the programs mentioned, visit whhs.com or call 800-963-7070, and please follow us on Facebook, Twitter, Instagram, and YouTube.
I wanted to, before we get to the Employee of the Month, talk a little bit about what's happened in the last month with Senate Bill 1152 and its impact on the hospital. You might recall last month we discussed what the bill provided for basically placing full responsibility on the hospital for the burden of the homeless who choose to come to the hospital. In January, we had a total of 251 homeless encounters. We had several patients that had more than one encounter. It's not unusual for a homeless patient to come into the emergency room, leave, and then come back again in the same day, sometimes 3 or 4 times in one day. 93 of the 251 encounters were just such encounters. The accrued cost is something that we are refining. This is an estimate, but we estimate that it is a net loss of $620,626. We will be refining those estimates. I'm not certain that all of the labor costs are in there. a lot of these patients take a great deal more staff time than our usual and customary patients. In terms of services, 85% of them were seen in the emergency room only, and 13% were admitted as inpatients. 2% of them went to observation. 5 were brought here by law enforcement, 5 more eloped, and 4 more left against medical advice. So that's kind of our experience. I also had discussed an interesting homeless patient last month who is still with us this month. He is a terminally ill homeless patient with a long history of mental illness. He lacks the capacity to care for himself and to make decisions. We have made extensive efforts to place him in a facility that can care for his mental and physical needs. As with many patients like this, we've experienced behavioral issues that are very complex and require daily, extensive resources to manage. The Social Services Department has outdone themselves with regard to this particular patient. He has been in and out of Washington Hospital over the course of many years, and we have never known him to have any identified family members. I want you to know that through their extraordinary work, they were able to identify and bring to the hospital a brother who he had not seen in decades and a daughter who he had not seen in decades. Unfortunately, the family's not prepared to take responsibility for him, so he remains with us. But I think that Janet McBride, who's head of our case management department, did an amazing, humane, and commendable act in finding his family. And he did recognize them, which was really extraordinary. This patient has had 11 behavioral emergency response team codes, which means that he has grown aggressive or violent, and we've had to call code Berts. We, as I mentioned last month, had 8 employees injured by him. And the number of medical disciplines and resources that it has taken to take care of him while he's been with us have included, on the physician front, intensivists, hospitalists, and a psychiatrist, registered nurses, the crisis nurses, social workers, case managers, security, who is assigned to this patient 24/7 now, compliance, administration, and also the input of legal counsel. We have learned that there really is no place to go in the sense of finding a place for him. In order to get him conserved, it takes 90 days. And even then, there's no guarantee that he would be placed by a conservator in Napa. In fact, we've been advised by counsel that that's not going to happen. And this is county attorneys that are telling us that. So this gentleman who is terminally ill, without sponsorship, mentally ill, I'm afraid is with us for the duration. So that's my report on Senate Bill 1152. I'd like to introduce our Employee of the Month now. Could do that for me? Thank you. I'd like to introduce you to Mazabin Hussein. And her coworkers say that caring for others is something that comes naturally to her. For several years at home, she was involved in the care of her grandparents, and her responsibilities included taking them to medical appointments and making sure the instructions from doctors were followed. She was raised in the area, attending James Logan High School in Union City. And in 2011, when she learned about an opportunity to work at the hospital as a unit clerk, she happily applied here. She works on 6 West, and she sees patients who are post-surgery. She works on the evening shift, and she greets family members and answers call lights and brings patients fresh water or an extra blanket, or perhaps just a happy greeting, a smile. She describes her best moments as working with patients. When they come out of surgery, patients can be disoriented, uncomfortable, or overwhelmed, she says. And then there's always that one day, sometimes the next day, sometimes not for a few days, when I can see that they are feeling much better. They smile in response to me, and that makes my day. That's a direct quote. Physicians and nurses depend on her to take calls, work with ancillary staff, and generally lend a hand whenever needed. She's working towards her bachelor's degree in nursing and plans someday to work as an RN at Washington Hospital. I couldn't be more pleased about that. When not at work or at school, she enjoys outdoor time with her husband, Khalid. Together they hike, bike, and take nature walks in places like Tahoe or the desert. Very proud to have her as our Employee of the Month.
Thank you very much, Nancy. We're ready now for our quality report from Mary Boron. I'm sorry. Looks like she's not.
What, she's not here?
Should we perhaps move to the finance report first?
Okay, why don't we do that? Chris is here.
Chris is here. And we'll hear from Chris and then
What's going on?
go back to our quality report. I saw her here earlier.
I did too.
Okay.
Okay.
Chris, we're ready.
All right. Tonight we'll be looking at the operational financial results for Washington Hospital for December. Average daily census for the month. All of our inpatient statistics lower than expected. Average daily census about 20.5 below budget at 158. We had 963 admissions. We'd expected 1,130 for the month. And our patient days came in 635 below budget at 4,917. Outpatient observation equivalent days in December came in at 174 against a budget of 130. We are seeing more patients being admitted to that service versus a longer length of stay. So seems like these are appropriate admits. Our average length of stay for the month came in pretty darn close to budget at 4.93. We'd expected 4.91. Moving into operating indicators. Case mix index for the month, which is our indication of the severity of patients we saw in December, came in lower than budget at 1.398. Deliveries for the month were 9 below budget at 144. Surgical cases in December came in 39 below budget at 339. That includes our joint replacement cases that were 9 below budget at 120. Neurosurgical cases that were 12 below budget at 23. And cardiac surgical cases, actually a bright spot there, 3 above budget at 11. Cath lab procedures for the month were pretty close to budget, 16 off at 308. Our outpatient visits came in at 6,562 against a budget of 6,952. And our emergency room visits came in a little bit below, well, a bit below budget, 442 visits below budget at 4,350 as we continue to see lower volumes in the ED this year. Quick look at the cath lab activity for the month. Peripheral vascular procedures really with the majority of the procedures at 42%. Cardiac procedures made up 36% of the activity. Non-vascular interventional radiology procedures were 21%. Moving into productivity. Productive FTEs for the month came in 100.6 below budget at 1,229.9. Non-productive FTEs for the month were 260.7, giving us total FTEs 104.7 below budget at 1,490.6. Our full-time equivalents per adjusted occupied bed, which is our productivity indicator, came in 0.17 below budget at 6.64. So, management, applaud to them. They're really doing a good job of managing to the volume. Moving into the financials, first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation we're required to use for our audited financials. Total patient revenue for the month came in a little over 5% below budget at $170,882,000. Our deductions for the month came in below budget at 76.99%. We'll take a quick look at the makeup of that. We really had a favorable payer mix as far as sponsored patients. Our contractuals for those patients came in 74.29% against a budget of 75.77% of gross revenue. However, our provision for bad debt and charity, as we've seen, continues to run higher than anticipated. For December, about $4.6 million of provisions for those patients. We had expected $3.767 million. Moving into net operating revenue. So the favorable payer mix actually really worked in our favor in December. So really net revenue just off 1.5% at $39,777,000. Operating expenses for the month, about $886,000 below budget at $39,343,000. That variance driven by salaries and wages with our lower FTEs. Benefits were lower. We had lower health and welfare claims in the month that were offset by some higher than expected workers' comp claims, but net positive variance. And that's really what drove those numbers for the month. Supplies with our lower levels of activity were lower, primarily driven by our prosthetics were lower than budget. IV solutions, the supply issues we were talking about last year seem to have settled down, and prices therefore have come down to more reasonable levels than what we were seeing during the great saltwater shortage of 2018. And also the supplies were driven down by drugs. Drugs were about $170,000 below budget for the month. So we end up with operating income from a GASB perspective, actually $261,000 higher than expected at $434,000. Non-operating income for the month came in a little over $1 million above budget, primarily driven by an unrealized gain in our investments. As you recall, December, the stock market had challenges, and the flight for what folks perceive as safety into bonds that we hold drove our prices up. So we end up the month with net income from a GASB perspective, a little over $1.3 million above the budget at $1,362,000. Quick look at the Financial Accounting Standards Board format. This is a way that financial statement you just saw might be adjusted by folks on Wall Street to look at us. In our GASB, as you recall, in our GASB presentation, we show our interest expense down in non-operating income. FASB likes to see it up in the operating expenses. So we make that adjustment and we end up with operating income from a FASB perspective, still $293,000 better than we expected with a $407,000 loss. Our non-operating income gets adjusted by pulling out our tax revenue that supports the debt service on general obligation bonds and that unrealized gain on our investments to come up with non-operating income of $409,000 and a total bottom line pretty close to break even. Quick look at EBITDA. This is earnings before interest, taxes, depreciation, and amortization. This is a way of looking at our financials to kind of get a read on the kind of cash that the operation's spinning off. What we do here is we pull depreciation out of our operating expenses to come up with an EBITDA of a little over $4 million, a little over $4.1 million. Also, we pull interest expense out of our non-operating income to come up with non-operating income excluding that of almost $3 million. So for the month of January, the hospital spun off a little bit over $7.1 million to provide for payment on that interest expense and other kinds of expenditures that we make outside of the operation. So are there any questions on December? Okay.
We'll now have operations report.
I want to begin the discussion of our preliminary results for January with the information that when we did this budget, we had anticipated that by January, we would have had the first price increase in the hospital in 5 years. For reasons that are confidential, related to business, that did not happen in January, so all of the budget numbers will be slightly off. And will give evidence of the fact that we didn't do this in January when we initially thought we might. Our business purposes for that will be discussed with the board in closed session. So for January, we have gross revenue of $202.9 million, below budget by 6.2%, or $13.5 million. Inpatient gross revenue of $142.1 million was below budget by 16.1%, yet 2.6% above January a year ago. Outpatient gross revenue of $60.8 million was above budget by $13.8 million, or a 29.4% positive variance. And it was also $17.3 million above January in 2018. The shift from inpatient to outpatient, again, as in prior months, is primarily related to the outpatient setting for joint replacement. In addition to not implementing the price increase, we have other major drivers of the revenue variance that bear mentioning. Our room and board revenue was down by 8.8 million. Inpatient days were below budget by 541, or 8.3%, and that drove our room and board revenue down by 2 million. Emergency room visits were below budget by 750, or 14%. And that drove our emergency room revenue down by 1.3 million. The lower level of inpatient activity drove ancillary service revenue below budget by 4.8%. Cath lab procedures, however, were above budget by 15.6%, driving cath lab procedures revenue above budget by 4 million. Average length of stay was 5.18. and it was above the budget of 4.88. It was longer than January a year ago. Outpatient observation days were 70 in number, above budget at 207 days, and this was also above January a year ago. Average daily census of 193 was below budget by 17 admissions. The admissions came in 272 below budget at 1,062. Major drivers of the admissions variance are the shift of joint replacements to the outpatient setting, deliveries coming in below budget by 39, neurosurgical admissions being below budget by 7, and cardiac surgical admissions below budget by 3. All other product lines were below budget by 141 cases. Patient days of 5,972 came in below budget by 541. Total surgical cases in January of 428 were above budget by 14. Surgical cases were 47 more than January a year ago. Inpatient surgeries were 85 below budget at 233. Outpatient surgeries were 99 above budget at 195, and they were 96 above January a year ago. And again, the increase in outpatient surgeries is primarily due to the joint replacements being moved from inpatient to outpatient, according to the new Medi-Cal requirements. Neurosurgical procedures were below budget by 7, but they were 2 more than we had at the same time last year. Joint replacement surgeries were 6 below budget, but 2 above January last year. Cardiac surgical procedures came in below budget by 3, and were 2 below January a year ago. General surgical procedures were above budget by 30, and they were 45 above January a year ago. The cath lab procedures for January numbered 400, and they were 54 above budget and 92 above January a year ago. Inpatient cath lab procedures were above budget by 54, and they came in at 244, and they were 96 above January a year ago. Outpatient cath lab procedures were on budget at 156. Peripheral vascular procedures were above budget by 49, and 58 more than a year ago the same time. Cardiac procedures were above budget by 9, and 29 more than a year ago at this time. Neurointerventional radiology procedures were above budget by 3, and 5 more than January a year ago. Non-vascular interventional radiology procedures came in below budget by 7. And we mentioned deliveries earlier. They were below budget by 39. We had 110 deliveries for January this year. Non-emergency outpatient visits. We had 7,845. They came in above budget by 7.1%, or 522 visits. We exceeded the number of visits January a year ago by 553. Lab visits were above budget by 293. Infusion visits were above budget by 82. Rehab visits were above budget by 82. Cardiac rehab visits were above budget by 69. The emergency room visits of 4,607 were below budget by 750, and below the same period last year by 347 visits. Our emergency room volume assumptions were driven by input we received from our consultants retained to help us with the move, who advised us we should see anywhere from 10 to 40% increase in emergency room volume as a result of opening a new building, and that clearly did not materialize. Our productivity indicators were below budget. Productive FTEs were below budget by 9.5%, or 143.1, at a total of 1,365.6. Non-productive FTEs also were below budget by 3.1. Total FTEs of 1,540.8 were below budget by 8.7%. Total productive FTEs per adjusted occupied bed of 4.96 were below the budget of 5.62. Total FTEs per adjusted occupied bed of 5.6 were below budget of 6.29, 11% positive variance. Sorry. The Washington Outpatient Surgery Center had 486 cases in January. That was 28 cases above the budget, and 51 more cases than January a year ago. Clinic visits of 3,668 were below budget by 557 for the month. That's a negative variance of 13.2%. Washington Urgent Care was down by 356, Nakamura by 99, Newark by 49, Warm Springs by 33, and the Ohlone Clinic by 20. In terms of our payer mix, our preliminary information indicates that government-sponsored patients made up 74.1% of total gross revenue. That was above the budget of 72.6%. And as the government-sponsored programs do not pay the cost of care, this is not a good variance. HMO revenue was 3.2% of gross revenue, which came in above budget. We had budgeted 2.9%. PPO revenue was 21.8% of gross revenue, which came in below the budget of 22.2%. You can see the payer mix is not working in our favor. Private pay revenue was 0.9% of gross revenue, and that came in below budget. We had budgeted 2.3%. Gotta do well somewhere, I guess. In terms of our key financial statistics, days cash on hand for January ended at 144 days, down 20 days from last month. The major impacts on January cash is the bond draw of $15.4 million, the revenue bond interest payments of $5.6 million, and we had 3 payrolls in January. Came early this year, and that was 7.6 days all by itself. Days of gross revenue and accounts receivable were 56. So the finance division is doing a great job. There were $598,626 in charity care applications pending or approved in January.
Informed that Mary will be unable to give our quality report this evening. We'll take that next month and have that done. So now we have several action items to consider. We'll take those from Dr. Nicholson. Item A.
Item A, Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the purchase of 2 SCN Hamilton G5 with Neo-Mode ventilators for an amount not to exceed $68,676.
We have a motion. Do we have a second? We have a second. Nancy, would you like to explain that just a little bit to the public?
It has a very simple explanation. These ventilators are 17 years old. They are currently at end of life. The vendor is no longer able to provide parts and service.
First babies are now well into their teens. So, Dee will take a vote on that.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Wallace.
Aye.
Director Danielson.
That motion passes. Item B.
Item B, Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to enter into the necessary contracts to proceed with the purchase of 2 StatGo compact coagulation analyzers for a total amount not to exceed $82,376.
We have a second on that. Dr. Eapen. Nancy again.
I'm going to opine that coagulation analyzers don't last as long as baby ventilators. These pieces of equipment in the laboratory are 6 years old and reaching end of life. They are on a lease which ends in March of 2019. As a stroke center, it's imperative that we have this equipment. It couldn't be more integral to the health care and safety of stroke patients. We need to replace them.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Eapen.
Aye.
Director Wallace.
Aye.
Director Danielson.
That motion passes. Thank you. Item C.
Item C, Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the purchase of the GE Acer for a total amount not to exceed $92,863.
We have a second on that.
Second.
Have a second, Nancy again.
There is a special kind of software that you can put on CAT scanners that reduces the amount of radiation a patient is exposed to. And it's called Adaptive Statistical Iterative Reconstruction. And our two newer CAT scanners have this software. The CAT scanner that is in the the Washington West building does not have this software. And we would like to put it on this machine.
Very nice for patient safety.
It's an important thing to do.
D.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Danielson?
Thank you. That motion passes. Item D.
Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors authorize the Chief Executive Officer to enter into the necessary contracts to proceed with the purchase of the GEAW server for a total amount not to exceed $163,821.
Thank you.
Second.
We have a motion and a second.
This is also equipment to add to, I beg your pardon. Kimberly, could you come up and read this? I can't stop coughing. I apologize.
I have a sheet. Yes, we're recommended moving forward with the purchase of the GEAW server upgrade to our existing CT scanners, and this will allow us to do 3D visualization capabilities on all of our reading locations with the CT scanners. And it will allow us to really process and be more precise for our CT scans, especially in relation to stroke.
Great. Thank you, Kimberly. D.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Danielson?
That motion passes. Item E.
Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the purchase of the Voluson ultrasound for a total amount not to exceed $34,369.
Do we have a second?
Second.
We have a motion and a second.
I think I can do it now.
Okay.
Tonight we had a wonderful presentation on our maternal and child health programs here at the hospital. The portable ultrasound that we use is not sufficient for the mission that we're beginning to pursue. We are starting to care for higher acuity preterm patients, and we need an ultrasound machine that renders better visibility of fetal organs, and the piece of equipment that we're requesting will provide that. It is a 2D image high performance ultrasound, and I think that the good it will do our birthing mothers and their young babies well warrants the expense.
Thank you. D.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Danielson?
Motion passes. Item E. I'm sorry, item F.
F. Mr. President, in accordance with district law policies and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the installation of the perimeter fence for the 2000 Maury campus for a total amount not to exceed $119,315.
I have a motion and a second. Nancy?
Well, this is the natural outcome of having completed our building. All the construction fences are going to go away, and they have to be replaced with an appropriate fence for the property. And this is part of that deal.
I was driving by today and thinking how nice that would be to have that fence up.
Yep. It'd be nice to get rid of all the construction fencing, too.
That's right.
Will look a lot prettier.
Yeah. Dee, if you could take the roll, please.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
That motion passes. We're ready for item G.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to execute the appropriate documents to complete the purchase of the navigation and imaging hardware and the 5-year software subscription from BrainLab for a total amount not to exceed $1,488,125.
Thank you.
Second.
We have a motion and a second. Nancy?
In February of 2011, the Board of Directors purchased a BrainLab suite for the neurosurgery operating room. And this navigation equipment is used with advanced imaging for the placement of screws and rods in spinal surgery patients. Equipment is at end of useful life. It's time to buy the neurosurgeons some new equipment. The equipment that they've identified for acquisition is the fixed BrainLab navigation system for OR1, a mobile navigation system to be used in other operating rooms, and an advanced Zyme C-arm imaging system to be utilized with both navigation systems for the placement of hardware in any part of the spine.
Thank you. Dee?
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
That motion passes. Item H.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the upgrade to the Facilities and Biomedical Computerized Work Order System for a total amount not to exceed $31,187.96.
Second. We have a second on that. Motion and a second. Nancy, if you'd explain that.
Happy to explain. This is a system by the Phoenix data system for work order and reporting for our facilities and biomedical departments. And this upgrade would allow the system to be used in a decentralized fashion so that techs can utilize it on the floor and access equipment history and new work orders while working on the equipment. And as our campus has grown, this is a bigger and bigger issue for them. In addition, there's a digital dashboard and a dispatch center that will allow for better reporting and management of personnel who've been assigned to work on biomedical or engineering work orders. And finally, there are improvements in the system that's going to make it easier and more intuitive for nurses and hospital personnel to put the work orders into the system. I think it's a good investment.
Good. Dee, if you take the roll.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
Motion passed. Tonight's a historic night. I don't think we've ever gotten down to far into these motions as we have.
We're not going to run out of letters, though.
Spent a lot of money.
Yeah.
Besides the letters we're spending. Okay, number I.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the installation of the line leak detection system for diesel oil for a total amount not to exceed $29,780.
Second. We have a second on that. Nancy?
I think the item really speaks for itself. We can't have oil leaks into the water table. I mean, that's just not acceptable. We want to be a good partner in our community. We have to have a detection system that will alert us to a problem.
Agreed. D.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
That motion passes. We're now ready for J.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to proceed with the purchase of the electrosurgery unit for endoscopy for a total amount not to exceed $32,750.
Second.
We have a motion and a second on that item. Nancy?
The current equipment is 14 years old and in poor condition. And it is something we planned to replace.
Good. D, we're ready for a vote.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
That motion passes. Item K.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors authorize the Chief Executive Officer to execute the appropriate documents to complete the replacement of neon lights with white LED lights for a total amount not to exceed $36,175.
Second.
And we have a second. Our lights for the building.
Our lights are burned out. We have to change the light bulbs. We're making a recommendation. Yep, I think they will.
Good.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
Motion passes. To all of our relief, we are to item L.
Mr. President, in accordance with district law, policies, and procedures, I move that the Board of Directors approve the amount of $688,000, $668,000 to cover the cost of expected tenant improvements to the Fremont office building through the end of this fiscal year.
Second.
We have a second on that item, Nancy.
It is what it is. We anticipate that the new terms on the leases to be between 36 and 60 months, and we've estimated the cost of expected tenant improvements on these spaces to total that amount. This is an estimate, but rather than bring these things one by one, we thought that we would group them and ask the board's permission to deal with them that way.
Sounds good. D.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
Director Wallace.
Aye.
Director Danielson.
Thank you. That item passes. I've made an error earlier in the agenda that I need to correct, and that is Jeannie said this was her last meeting. And I need Jeannie to give you the thanks of the board. It's been an absolute pleasure to work with you. You're a wonderful leader. You've been very efficient and very, very hardworking. I've even ridden a float with you.
I know.
And and she's quite good at the wave. Anyway, I wanted to publicly thank you, Jeannie, for all that you've done these last years with as president of that wonderful organization.
Truly been my privilege.
Well, thank you very, very much.
Thank you.
We're at a point in our agenda now where we need to adjourn to a closed session, so we'll now adjourn. We reconvene the meeting now to an open session and announce that no reportable action was taken during the closed meeting. Seeing there is no other business brought to the board this evening, this meeting is adjourned. Thank you very much.